which is Therapeutics and Interventions. And we open this with a panel discussion on advances in longevity therapeutics, moderated by Professor Ramray Bhat from the Department of Developmental Biology and Genetics. We have on the panel Dr. Vishal Rao, who is an oncologist and dean at HCG Global. We have Dr. Harshavardhan Rao, who is a professor of gastroenterology at MS Ramaiah Hospital, and Professor Subba Rao, who is a longevity team member and also a professor at the microbiology and cell biology department at IISc. I request all the panelists to come on stage, please.
Welcome everybody to this session panel on advances in longevity therapeutics. Alertness alert. I don't know if this is by intelligent design, but again, my name is Ramray, and fill in the blanks. It takes one Rai to engage three. So, all right, with that we get started. So since this discussion session would be on longevity therapeutics, and therapeutics of course impinge both in terms of preventing as well as intervening in disease progression. We are indeed privileged to have members of this panel both as clinicians as well as Professor Subba Rao, who's an active, engaging scientist in this zone. So I'll start by asking a few questions, and then we can sort of take it on more organically as we go along. So my first question would be to Dr. Harsha, and the question is like, how in your experience do you find treating in the gastro space, but even in general, treating a geriatric population, different from the younger population which comes to your outdoors and so on?
Yeah, thanks for the question, Ramray. There's a few, I think, kind of like guiding principles in geriatric medicine in general, not just GI, right, which I'd like to highlight, which makes treating a geriatric population a challenge as compared to the younger population. First is the fact that they are truly a heterogeneous population. If you look at the heterogeneity in the geriatric population, it is very wide, and it doesn't even compare to the kind of variations we see in the younger population, right? So the subgroups are very few, but a large number of subgroups within the geriatric medicine population, right? The second is the depletion of the physiological reserve as you get older. And what I mean by that is each organ system depletes, its physiological reserve starts getting contracted, right? So the normal values that you see that are usually put in lab values, right, may not necessarily apply to a lot of these geriatric medicine patients. For example, I'll give you an example. Recently, I had a patient who came in with hypoglycemic symptoms, but his sugar was 98. But when you look at it, it's not really hypoglycemia, but the patient had symptoms, right? And when you look at that, so that's there. The normal values do not kind of like come close to what the younger population have, right? What we call as homeostenosis, right? So that's specific for the geriatric medicine population, and that's something that most physicians have to deal with on a daily basis, right? And the third one is the fact that our treatment approaches have to be tailored to every patient, right? Because of the fact that there are multiple paradigms of factors that affect their end goal. Like, for example, it's physical, there's mental, there's social, there's cultural, economic, because they have dependence, right? So a lot of our treatment has to factor in these aspects, right? So that, we make a decision customized to that patient, right? So geriatric medicine is I think, the prototype of personalized medicine, right? We actually, I think that's why even Longevity India, I think that's where it really kind of like shines through, because geriatric medicine is the prototype, is the kind of population that will massively benefit from personalization and customization.
Excellent. I'll carry on that point as we move along. Professor Subba Rao, from your experience, and I'll give you the mic, you can just take that one. From your experience in cell biology, for example, how does an aging tissue pathologically differ from younger tissues, and what's been the research in this zone?
So, at the tissue level, because most of the research we use is all cancerous cell lines, which is difficult to monitor whether the cell is aged or not. But it's clearly that when you use primary cells, definitely if you isolate a primary cell from a mouse, availability of the tissue sample, mostly you will start seeing the aging within 7 days of the tissue culture itself, because you don't have the proper environmental conditions to maintain continuously. Second, it also has a lack of signaling between the other cell types. It's a communication gap between the neighboring cells versus the cells of which you are growing in pure culture form. So it becomes very difficult to judge whether you are promoting aging in a faster way in a tissue culture dish, or you are changing the parameters of the tissue itself or culture itself to do the job. So most of our experiments we do mostly early age, roughly in the passage like 5 or 4. But by the time the acquiring enough cell mass for your experiments also limitation. So it becomes very challenging for a proper tissue, especially in healthy patients, getting a non-contaminated or pure form of a tissue culture based experiments become challenging. However, the slightly different way of doing it is the animal model level. People are quite used to the animal model level, at least it becomes a primitive in nature to apply to the human level. That also a complexity advice.
I see. But, in, say, animal systems, if you were to employ aged animals versus young animals, the very fundamental biology, is it very distinct in terms of if you take a certain organ, I think the organ that you are an expert in is skin. To what sort of qualitative level does, say, an old skin differ from a new skin such that we can harness therapeutics and so on?
So at the basic cell biology level, the age parameter means what we have a proliferative cell pool decreases quite a bit. So and the rate of proliferation reduces automatically again come back to the genomic level what you have the stuff. But at the proliferative level reduces, then differentiation reduces, tissue quality reduces, and then mostly also depend upon the secretory parameters by your differentiated cells. So you end up with the secretory parameters of the cells either by neighboring cells or autocrine versus paracrine, or within the cell pool that whether you are making a proliferative to differentiation at a faster rate. At early age, you have a high capacity for proliferative, where as you go on age, it's reduced. So most of the medicinal value is to how to keep the proliferative cell pool as an intact, and how fast you make a differentiation in a disease conditions is a good way of looking at the therapy.
All right, that's great. Dr. Vishal, you are one of the leading experts in the world on head and neck surgery, cancer surgery. So you must be getting patients from across age spectrum. In your decisions on therapy and surgical interventions, is there a qualitative difference between the way you look at the aged population and therefore take decisions on interventions with respect to, say, the younger population that comes to your clinics?
So I think broadly, Ram, I think as we talk about cancer, it's somewhere an age-specific thing that although we are seeing pediatric cancers now, younger cancers, and the trends are changing, but it's more to do with majority of them coming at a certain age group beyond the 5th decades, in majority of them. So aging is somewhere related to the part which Professor Rao told about, the regeneration-degeneration mismatch. And in this, there is going to be some amount of accumulated genomic instability that expresses itself because the overall repair mechanisms are depleted. When I take a point from a therapeutic stand, what I have seen in my practice over the years is the last one I operated some time back was a gentleman who was 104 years. Now, I was trying to convince him that he should not get operated because I was worried, and he kept telling me that I'm not a confident surgeon. So I was trying to logically argue with him, and he said, look, when HAL completed 100 years, I did my centenary with him, what are you worried about? So now, how do we objectify this? Because I was actually thinking, because I knew the family and I was very cautious, I said, we should not, and it was an advanced tumor. Where do we draw the line for this? So just to tell this gentleman's story, so typically, we have an objective scoring system. We follow an American College of Surgeons standard risk stratification system to say beyond age, what does he come into the profile and what are the predictable risk factors which we have data for. So we put him through the cardiac check, we put him through the pre-anesthesia check, the ICU team evaluated him. I searched every reason to cancel the case. I couldn't. I ended up operating on him. So of course my consents, my counseling was from death on table to complexities to prolonged ICU stays to typically people go back in about 7 to 8 days. He went back in 5 days. So I had not much to it was quite, so the bottom line in this entire learning for me was, we have a biological age, we have a physical age, we have a mental age. Sometimes we misconstrue the physical age and the biological age and kind of interchange it. I don't have the answer, but what I have now do as a systematic thing is I do not keep age as a criteria. I say that age is one of the parameters which has to have a biological correlate, which is very important. The mental age part of it can be dealt with the psychologist, and the physical age part of it may not matter. Then we are able to do this kind of a customization. And I would allude to the today's recent evolution in the industrial era of mass customization. See, this concept is evolving in healthcare today, and I think age is one such area where actually mass customization will pick up in a very big way.
What do you mean by mass customization? Can you just elaborate?
So it was just I think a couple of decades back, this whole thing was a part of industrial revolution, and I think if I'm not wrong, it came from a book called Future Perfect. Okay, this terminology came from Davis's book called Future Perfect, called mass customization, wherein for Starbucks, for example, he has to customize coffee, but he can customize it to each person at a scale, mass, but yet at low cost. So healthcare is now dabbling with it. And I'm talking about this because I'm personally working on this at that front to understand how do I apply personalized medicine and precision medicine at a mass customization level.
I see.
Thank you.
I see. Thank you. Dr. Subba Rao, I would like to sort of take this forward towards, some of this ideas of, say, heterogeneity that Dr. Harsha alluded to, as well as this, divergent clocks that Dr. Vishal was talking about. So, how far are we in our, say, experimental models in sort of incorporating some of these interesting features, which we would perhaps not think of if we were not thinking about the aging research to begin with?
So I go with at the cell biological level. So you can take a skin, heart, liver, pancreas, any cell models you take it. The basic steps for cell biology running the cell day-to-day life is same. However, the expression pattern changes. That's why why they are called as a liver cell or the skin cells are different. But how they respond to the environment is also different, because skin exposes most of the outside environment in addition to this microbiome which is present into it. In addition to the dermal which is present in the bottom and melanocytes which also protect your keratinocytes, DNA and all the stuff. So in those cases, the multi-complexity comes for certain organs. So a single compound or any therapeutic which you try to do it for that, we have to carefully evaluate for each organ. But anyway, in reverse gear is that because the aging is also, people believe that is organ specific. Now you come back with a specific organ, specific format and see that. But in a early development, make sure that the drug or any therapeutic which you look for it's look at it at a multi-organ level. Then only it will work out. That's why the small animal models are much more useful at the initial stages of therapeutic purposes. But however, the later doesn't correlate. But however, it depends on the stage and all the stuff. So moreover, most of the model system, what we have is a background of immortalized. So where you already manipulate the DNA to go continuously. So in those cases, whether the reflection onto the natural system is 100% correlates or not, we need to be validate. That's also a significant challenge in the therapeutic field, which always need to be carefully evaluated for a particular set to set of the experiments what you design for it.
Thank you. I have a couple of follow-up questions, but first I'll ask one more question, Dr. Harsha, and that's, other side, and coming to the therapeutics specifically in therapeutic interventions, are the side effects that you see of these therapies qualitatively or even quantitatively, very distinct in the older patients you treat for the same disease that you would treat for younger patients? And is that something on your mind when you...
Absolutely. I think when you look at adverse events, I wouldn't just say side effects. Side effects is usually for pharmacotherapy, but adverse events in the elderly, right, is very different from adverse events in the younger individuals. First of all, and it's very difficult to predict adverse events in the elderly, and that's mainly because I think in continuation with what Dr. Subba Rao also said, when you look at organ-specific aging, there's different rates of organ-specific aging, right? So in an individual, you will have different rates, so each system would have aged at different rates, right? So when you look at the possible effects that any intervention or medication can have, it will vary with each person, right? And because of this different rates of aging, you'll have atypical manifestations of side effects also, right? For example, when you have, we had recently a patient with UTI, when we had given some medications, an elderly individual, the patient came up with breathlessness, which actually turned out to be not related to the respiratory system per se, but because his lungs were fibrous, his lungs had kind of like aged a lot faster, he manifested with that first. Right, and also you have to look at the resilience of an of an individual when you look at prescribing any medication as well as intervention. Right, I'm sure Dr. Vishal will also agree. When you look at that aspect, you have to look at with what certainty can you say that after an intervention will the patient be able to bounce back to his kind of like baseline level of functionality as well as frailty, right? So all these are mitigating factors, and these are things which make geriatric medicine so challenging in terms of therapeutics.
Thanks. I have so many follow-up questions now, in response to the responses that you gave. But I would probably open up this to the audience, and if there is time, we'll come back again, back to my favorite questions. So,
at what age you see the differences? Like, from what age you see there is a difference between young adult and like who you call geriatric?
Yeah, so that is a very, very provocative question, and I think, though I would fall back on what Dr. Vishal said about the fact that age is no longer kind of like a criteria for us to decide whether this patient is at a disadvantage when it comes to health related interventions as well as medication or therapeutics, right? Even in my practice, when I look at endoscopy, I say when patients come in and say, "Oh, I'm so and so old. Do you think I'll be able to tolerate the procedure?" And I say that's immaterial to me, right? Let me look at your organ systems. Let me look at your functional status. Let me look at these aspects, which will give me more information on whether you'll be able to tolerate the procedure rather than age as a single statistic. So I would say age is just a number. I do not think we can draw a line as to whether a patient is aged at a certain level. Okay, so when you look at data and literature, right, most of them allude to cutoff of between 60 and 65 for most of the diseases. I do not agree with that, right? I believe that is changing now. Those data, the data on which that was decided is no longer applicable in today's world, right? So I do not think that there is a cutoff. I've seen 50-year-olds behave like 70 and 80-year-olds, right? At the same time, we have seen 80, like he said, a 104-year-old who has behaved much better than a 50 or 60-year-old in the current sense, right? So the data on which those cutoffs were made are, I think, no longer applicable in today's world. So I would not like to assign a number. Do you want to add something to that?
I just want to confuse that statement further and say that governments have suggested something. So I think that cutoff is also by the government only. So you could add that thing to say that government has defined aging on that. So biologists have not defined that. Finance systems, governments have defined it.
Dr. Vishal, if you can
even
just hold on.
as per curricula, they say young, old, and old. That is between 60 to 75 is young, old, and 75 older is old. To me, it's meaningless. I don't think that makes any kind of like clinical correlation.
Vishal, I had a question for you. As a cancer biologist, I have dibs on this first, but we know from a lot of data, epidemiological data from the West, that cancers come in older populations, 50s, 60s. What is that something that you see in India as well? I'm just trying to see what kind of support we have in our South Asian region, not India.
Yeah, but I think overall, to go back to what we discussed, that the repair mechanisms are poorer, your immune system is depleting, and if you have had habits like tobacco or alcohol, or if you're exposed to carcinogens like unknown ones, pesticides, preservatives, there is a sense of already a kind of accumulated, I would say, oxidative stress that is actually going to manifest itself, and that's why it's somewhere related with that age group.
Sure. Questions back.
Hello, I am Dr. Prasun Chatterjee. I am from AIMS. I am a geriatrician researcher. So I'll just add few points with Dr. Hers and from my 2-decade experience as a geriatrician and researcher. See, again, aging starts in the womb itself. So don't consider aging has started only after 60. But few issues we need to think, like muscle loss. It starts losing. We are losing our muscle strength as well as mass from the, let's say, at the age of 40. So I tell my patient, every young people should exercise, but it is a must for elderly people to maintain your functionality. So functional ability is the key here. What WHO recently coined a term as called intrinsic capacity, which includes your mental, physical, overall capacity. So the problem with the difference between young population and elderly population is how rapidly they are bouncing back to their normal functional ability, we call it as pre-morbid status. So the point is here age number is very vague, as all of you are discussing that way. So that is all the more reason we researcher and clinician should find out biological aging more precisely. The difference between 94 or 100 and 70 is not the calendar aging, it's more of biological aging. There is similarly for cognitive capacity, it get rapidly deteriorated after 30s. So if you compare 30 plus with a 60 plus, 70 plus, but there are people, I conduct a study and it's published, we call as super ager. So their cognitive capacity, they are 80 plus people, we called as oldest old here. 80 plus people, their cognitive function is as good as who are 50 plus. So just imagine they could able to maintain cognitive capacity who are 30 years younger. In my study, I saw even much younger. So 94 years, I have an epitome of active aging, that way you can say. I have a book also, Health and Wellbeing in Late Life, if any of you are interested.
Dr. Chatterjee, we'll definitely engage with you.
So this is the point is don't like stigmatize a person, stating what Professor Vishal rightly mentioned. Don't stigmatize a person that your age is this. Right.
That's an admirable point, and I think we can even bring it down. I think somebody mentioned even cell aging at this stage. So I think there was a question from here. Yes, please.
So there was a recent paper in Nature Aging, I think, that mentioned that the conclusion was the aging occurs in 2 spurts. One around mid-40s, and then in the early 60s. And there were distinct changes that was observed at these 2 different time points. The cardiological ones, I think, around mid-40s.
Yes.
So what's your opinion on it? Do you also observe similar things in your patients? Like,
do we have a clinical correlate to that? Is that in our patients? Absolutely, right? So there is a clinical correlate, and what I'd like to highlight is, again, the fact that you're looking at different organ systems and looking at the rate of aging in each of the organ system. And at around 40 to 50, the paper did say that there is an accelerated cardiological aging, right? Even muscle loss accelerates, and at that time, cognition kind of like starts coming down, right? All of it, there is a clinical correlate for, right? But I do not want to put it as a kind of like a dogma and a generalization at that point, because we have seen it significantly diverge over the last 10 years, where you have people who are much more health aware, right, and are taking measures to kind of like, circumvent these normal physiological processes, or what we call as physiological processes, because of the data before, right, who are much more in a better place as compared to others in the past. at the age of 40 to 50, right? The second phase of aging, yes, 100%. There is a definite correlation there. But the early aging part, I'm not fully on board with it in terms of the current scenario.
And again, it's likely to be very heterogeneous. I think
Yes,
that point is, yeah, it mentioned 44 and 43, it really freaked me out, I would say. Anyhow, more questions at this stage?
Hello. Actually, in terms of therapeutics or prescriptions of drugs, right, there are a lot of drugs which induces senescence to treat any kinds of diseases, especially in case of cancers. But how can we prevent the senescence induced in other outside the body when we use drugs to treat cancer? Because we generally use cancers to become senescence, right, as a therapeutic model. So how can we do that?
No, I think, hello, the point is very valid. So the word could be chemotherapy. Correct. More precisely put, chemotherapy is the particular weapon that actually induces carpet bombing, mass senescence, and now the question is how do you actually do it? And I think globally there is a shift towards understanding and moving towards what we call as targeted therapy, and then towards more precision medicine to understand. And the whole question that was still unanswered in cancer was when you get a cough or a cold, your body throws out the foreign body, whereas here the immune system is lying latent. So all of work of immunology started with that aspect of understanding and looking at how do you train the cancer to understand its own, to be more precise, to be more targeted. Immunotherapy has moved in the same direction of targeted therapy. The whole search is towards understanding and trying to target senescence only to a subset of cells, not the entire group of all the cells. I think there is significant strides we have done in that area, and I think bottom line is we've still not given away with chemotherapy. You can't. Okay. Yet what we've understood is with chemo you can combat strategies on mitochondrial rejuvenation. I mean, this is a long topic. I think I'll have to take away the mic from Ram also. So, no, but I'm just saying mitochondrial rejuvenation would be the way when you have to do targets like this, which actually have a collateral damage of senescence on various cells. And that's what we work on, whether it's Ayurveda, whether it's yoga, whether it's meditation, whether it's nutrition. So, at our center, we have a complete multidisciplinary team of about 9 members only for rehab, because I believe that that is more important than surgical, medical and radiation onco, because that's a small subset of killing the cells, and then after that the rejuvenation part is equally important. So rehab centers, now with the National Cancer Grid also, we formed of 230 centers only looking at comprehensive rehab which looks at rejuvenation.
Brilliant. I just have one question for, oh yeah, please.
I think the same thing applies to not just in cancer, but across the board, right? Even when you look at ischemic heart disease, stroke, all of it is the money should be directed at rehab. The hopes should be directed at rehab, and the better you, the breadth of skill set that you have in the rehab, like Sir said, it's not just really about physical therapy, it's really about looking at every aspect of rejuvenation, and that's something that, so it works across the board. It's not just in cancer. Across the board, I think rehab is where you would really look at how your intervention has benefited and how to reduce the collateral damage.
What are the modalities of rehab? Can you just elaborate it?
So rehab can be across, when you look at the multiple areas that it intersects, it's physical rehab, that is the most common, right? Then there's mental, okay? Then there's social, then there's economic also, right? All of it comes in terms of rehab, and also it is preventive, to prevent progression and later kind of like, effects down the line. So all of it has to be addressed for you to have a good quality of life, right? And enable the patient to bounce back, like Dr. Chatterjee had said, to the pre-morbid state, right? So rehab is actually the one that helps you kind of like come back to your pre-morbid state, and also that's the one that also helps in longevity.
Excellent.
One line, I think in addition to rehab, prehabilitation has become a very important topic as a continuum. So when we, like in oncology, when we start on before rehab, we have a prehab sessions to look at understanding baseline assessments, customized needs, and then after that going aggressive on rehab in those specific areas.
I had a question for Professor Subba Rao. we hear a lot about organoid research. What's the status of organoid research in, say, geriatric experimental biology?
So the organoid sections this is a very good model system. It acts as a very good model system to test the efficacy or the translation potential of your any of the molecules which you want to test it. But still, it's actually a single mass of the different types of cells of pool, but it misses quite a bit of the immune system capabilities, which is not there in this one. So, but it's a good start to have better than the small animal models, which doesn't correlate a lot of them to the down the line of the stuff. So, not only the toxicity levels, potential of activation of the signaling pathways in the in organoid model system, but still it's actually a tissue culture model. So you end up with you have to go back into the animal model level to see the overall global change in the system.
Perhaps at the experimental biology level, we'll have to embrace multiple different models, which will give us multiple different messages towards.
That's perfect. That's they say that the organ specific organoids, then multiply this connectivity between them. It's basically.
Just, I think one of the problems with aging kind of like research is the fact that you have to wait for the entire model to age, right? And that's where, when you look at entire animal models, it becomes restrictive, right? When you look at, so I think the worms and there are a few kind of like models which have really kind of like helped. But apart from that, the problem is to kind of like assess them longitudinally, and the time span becomes logistical nightmare.
But then that's the trade-off of some of these animals being so departed from the human biological complexity. All right, do we have more time, or are we completely out of time?
I think we're done.
Done. Awesome. Okay. Or I think if there are bound to be several questions to the panelists, but please engage with them through this day. And the moderator. Oh yes. And I can. Sure. Thank you.
He's posing all the difficult questions to
Of course. I have that opportunity. So thank you so much. Thank you all. Thank you.
Thank you. Thank you.
Panelists.
Okay.